Welcome to the Rad-On Smart Review CNS Cancer series.
Great to be here.
Today we're sharpening our focus on, well, a really critical and complex area in oncology, how we manage brain metastases.
Yeah, absolutely. It's a big one.
We're going to work through some challenging clinical scenarios. The idea is to really strengthen your decision-making skills, get you ready for comprehensive patient care, sort of like you'd face in an oral board exam.
Exactly. And our mission today really is to take all this, sometimes complex information and distill it down. Make it memorable, actionable.
Right.
We'll use real-world cases, throw in some practical tips. Just make sure you get a really solid grasp on approaching diagnosis, planning treatment, and the long-term follow-up for these patients.
Okay, so let's start with the basics, the essentials. Understanding brain mets from the ground up. Now, we won't get totally lost in, super intricate neuroanatomy, but it's vital to get where these lesions often show up and why that location matters so much.
That's key.
For instance, we'll talk about cases in the left cerebellar hemisphere. Even a relatively small lesion there can cause major symptoms.
Yeah, because of mass effect, right. Pushing on things like the fourth ventricle, messing with CSF flow.
Exactly.
That's a crucial foundation. And then building on that, if you look at the bigger picture, like epidemiology, brain mets are a huge challenge. Growing challenge, really.
They come up so often.
So often.
Right.
And usually from common primary cancers, in the cases we'll discuss, you'll see how frequently primaries like breast cancer, metastatic melanoma, and that specific lung cancer type EGFR mutant non-small cell.
Right, NSCLC.
Yeah, how often they lead to disease in the brain. They make up a really significant chunk of the patients we see.
So when a patient comes in, maybe with new neurological symptoms or sometimes even asymptomatic lesions just found on a scan.
Which happens.
Right, a thorough, quick workup is just paramount. So what's the absolute first step? And are there any common, pitfalls to avoid?
Good question. With such a complex presentation, the number one priority is always clinical stabilization.
Okay.
Take our first case we'll discuss. A 65-year-old woman, progressive ataxia, so trouble coordinating movements, plus nausea, vertigo.
Classic symptoms.
Classic cerebellar signs. For her, job one is high-dose dexamethasone. You've got to manage that cerebral edema, the swelling around the tumor that causes so many of those acute symptoms.
So steroids first.
Steroids first. It can be a game changer, really improve things quickly neurologically.
Okay, stabilized. Then what about imaging? What do we order right away?
You need that brain MRI with and without contrast immediately. That's essential to really see the intracranial mass, define it.
Got it, MRI.
And at the same time, you need a CT of the chest, abdomen, and pelvis. The staging scans.
Right, the CT-CKP.
Exactly. You have to restage, see if there's systemic disease. The brain lesion might just be, the tip of the iceberg.
Makes sense. And performance status, that comes into play too, right?
Hugely. Her overall function. So in her case, she started with a Karnofsky Performance Status, KPS, of 70.
Okay, so needing some assistance.
Right. But then it improved to 90 after steroids and maybe surgery. That KPS score is a key prognostic factor. It really influences what treatment options are even on the table.
Okay, and pathology, if they do surgery.
Oh, absolutely vital. Tissue is the issue, right?
Yeah.
So in our first case, after resection, pathology confirmed metastatic adenocarcinoma. And it was consistent with her known breast cancer primary. That direct confirmation is gold.
That confirmation is fundamental, tells you the origin, helps guide systemic therapy.
Precisely.
And we'll see later in another case with that EGFR mutant lung cancer.
Yeah.
How critical those molecular markers are.
Oh, yeah, for tailoring everything. Systemic therapy, radiation decisions. It all hinges on those markers sometimes.
Okay, let's dive into this first case then. Really unpack it. So 65-year-old woman, solitary, enhancing 3.5 centimeter mass, left cerebellar hemisphere.
Big lesion.
Big lesion, significant edema around it, mass effect pushing on the fourth ventricle, causing early obstructive hydrocephalus.
That's serious?
Yeah. And her staging CTs, the CT-CIP, negative elsewhere. So just this one spot in the brain, what's the initial management call here?
Given the size, the critical location causing symptoms, that hydrocephalus, my immediate recommendation is an urgent neurosurgery consult.
Right away.
Right away, for maximal safe resection. The powerful thing about surgery here is it gives you the fastest, most effective decompression.
Relieves that pressure.
Exactly. It can reverse that neurological decline quickly. And, like we said, you get that crucial tissue for pathology.
Okay, so she has successful surgery.
Right.
Gross total resection. Now, there's a clean surgical cavity, measures about 4 centimeters across. Pathology confirms. Metastatic adenocarcinoma from her breast cancer. Now what? What's the adjuvant plan?
Okay, so post-op, my recommendation is adjuvant stereotactic radiosurgery, SRS, to the resection cavity.
SRS to the bed?
Yep. SRS to the bed. It's that highly focused, precise radiation. I would strongly argue against just watching observation.
Why?
Because the risk of it coming back right there, local recurrence, is really high, like 50 to 65% at 1 year. Too high.
Wow.
And critically, I would not recommend whole brain radiation therapy, WBRT.
Okay, no WBRT. And this is where things have really changed, isn't it?
Massively. This next point, it really reshaped the field. There was the NCCTG N1070C trial.
In the 1070C, right.
That trial showed post-op SRS gives you equivalent overall survival compared to WBRT, but with significantly less cognitive decline.
That's the key, the cognitive part.
That's the game changer. You get the same disease control without damaging the patient's cognitive function nearly as much. It's a fundamental shift to survival and quality of life.
So how do we actually plan that SRS? What's the setup?
Okay, for the planning. We'd simulate her lying supine, immobilized really well in a custom thermoplastic mask.
Got to be precise.
Extremely precise. Then we get a high-resolution CT scan with contrast, and we fuse that with her post-op MRI. That fusion lets us see the target cavity perfectly.
Okay, but it's a big cavity, 4 centimeters. Isn't single-shot SRS risky there?
Excellent point, yes. For a large cavity like that, giving the whole dose in one single SRS fraction carries a pretty high risk of radiation necrosis, damage to the surrounding healthy brain.
Right.
So the key insight here is to use hypofractionated SRS.
Meaning multiple smaller doses.
Exactly. Deliver the radiation in smaller doses over a few sessions, like 30 gray in 5 fractions or maybe 27 gray in 3 fractions. That approach significantly cuts down the risk of necrosis, but it's still very effective.
Got it. Fraction it for large cavities. What's the actual target volume?
The gross tumor volume, the GTV, is simply the surgical resection cavity itself on the MRI.
Okay.
Then we add a small margin, usually a 2-millimeter isotropic margin all around it. That creates the planning target volume, or PTV.
And why the margin?
That margin's crucial. It accounts for microscopic uncertainty and setup variations, and it's been shown to improve local control. The Stanford group showed that.
Okay. And risks. What do we tell the patient?
Need to counsel them, definitely. Acutely, short-term, maybe a fatigue, headache, pretty common.
Okay.
Long-term, there's still that risk of radiation necrosis, even with fractionation. For a large cavity, maybe around 10 to 15%. Lower than single fraction, but not zero.
Still a risk.
Still a risk, and also maybe a slightly higher risk of something called nodular leptomeningeal disease, especially for resections in the posterior fossa, like the cerebellum, and particularly in breast cancer patients. Something to watch for.
Okay. And follow up after this SRS?
We'd get a baseline brain MRI, maybe 2 to 3 months after the SRS is done.
Establish the new normal.
Exactly. Then keep doing MRIs every, say, 3 to 4 months for the first couple of years. Just keep a close eye out for any recurrence or new spots.
All right, that covers the resected lesion scenario really well. Now let's pivot.
Yeah.
Different situation. Multiple intact metastases. What do we do then?
Good transition.
So consider this.
Yeah.
45-year-old man, metastatic melanoma. He's actually stable on combination immunotherapy, doing well systemically.
Okay.
But his surveillance brain MRI pops up 3 new asymptomatic Mets, small ones. 1.2 centimeters, 9 millimeters, 7 millimeters. The KPS is good, 90. What's the recommendation for these intact lesions?
Okay. Multiple small asymptomatic Mets in a patient doing well otherwise. My recommendation here is SRS alone to all 3 lesions.
Just SRS.
Just SRS. I would strongly advise against adding whole brain radiation therapy. No WBRT.
And the justification for that, it feels like WBRT used to be the standard for multiple Mets.
It did, but the evidence changed things dramatically. This is based on level 1 evidence.
Yeah.
The Alliance N0574 trial.
N0574, okay.
That trial looked specifically at patients with 1 to 3 brain Mets, and it showed very clearly that adding WBRT to SRS results in significantly worse cognitive deterioration. Significantly worse. And critically, with absolutely no overall survival benefit. So you're hurting their cognition for no gain in lifespan.
So the standard of care shifted based on that.
Completely shifted. Preserving brain function became paramount when survival wasn't improved.
That really highlights that modern idea, right? That more isn't always better in oncology.
Exactly. Sometimes less is more. And, if you look deeper, there's a meta-analysis by Sagal. It suggested for younger patients under 50, adding WBRT might even be bad for survival.
Really? detrimental.
Potentially. It really forces you to weigh things. Sometimes that less aggressive approach, SRS alone, actually gives better long-term outcomes when you factor in quality of life and cognition. It's a powerful reminder.
Let's try an analogy for this. How would you explain SRS versus WBRT simply?
Okay, think of SRS like a sniper, a precision sniper.
Good.
It targets only the known lesions, the specific tumors, with extreme accuracy, leaves the surrounding healthy brain pretty much untouched.
Got it. Focused.
Very focused.
Yeah.
WBRT, on the other hand, it's more like a shotgun.
Okay. Wider spread.
Yeah, hits a much broader area, gets the whole brain, including lots of healthy tissue, so more collateral damage, higher chance of those cognitive side effects.
That's a great analogy, sniper versus shotgun. So for this melanoma patient, how do you pick the SRS dose for those 3 lesions?
The dose is tailored to the size of each lesion. We usually follow established guidelines like the RTOG 9005 schema.
RTOG 9005.
Right. So for example, for his 1.2 centimeter lesion, I'd probably prescribe 22 gray. For the 2 smaller ones, the 9 millimeter and 7 millimeter, maybe 24 gray.
Higher dose for smaller lesions.
Generally, yes, within limits. They can tolerate a slightly higher dose per fraction, and these would typically be single fraction SRS.
Single shot for these small ones.
Okay.
And the target volumes.
The GTV, the gross tumor volume, is just the enhancing tumor itself that we see on the MRI. Simple.
No extra margin like the CTV.
For intact metastases, typically no CTV margin is used. We just define the visible tumor. The PTV, the planning target volume, would then be the GTV plus a very small margin, maybe just 1 millimeter. Just accounts for tiny setup uncertainties.
And you mentioned controlling dose to normal brain.
Yes, critically important. We watch the total volume of normal brain getting a significant dose, like 12 gray, the V12. We aim to keep that total V12 below 10 cc, 10 cubic centimeters, helps minimize that necrosis risk.
Okay. And what about his immunotherapy? He's on ipilimumab and nivolumab. Do we stop it for SRS?
Ah, good question. Systemic therapy integration. Based on data, particularly from places like Johns Hopkins, it seems there might be a synergistic benefit between immunotherapy and SRS.
They might work better together.
Potentially, yeah. And importantly, without a clear signal of increased toxicity, at least for this combination.
So you'd continue it.
My recommendation would be to continue his Ipi/Nivo without interruption. Just proceed with the SRS concurrently. Let the systemic therapy keep working body-wide while SRS hits the brain spots.
Makes sense. Risks to mention for this patient.
Similar risks, mainly paralesional edema that's swelling right around the treated spots, and again, radiation necrosis, though the risk is generally lower for these smaller single fraction treatments compared to large cavities.
Okay. And follow-up. Still frequent MRIs.
Absolutely. Serial brain MRIs every 2 to 3 months.
Yeah.
Because even though we're treating these 3 spots, the risk of him developing new, distant brain metastases after SRS alone is still pretty high, maybe 50% at 1 year.
So you zap the ones you see, but new ones can still pop up.
Exactly. Gotta keep looking.
All right. Let's tackle our final case. This one sounds like a classic board question, a sequencing dilemma.
Okay, let's hear it.
58-year-old woman, newly diagnosed with EGFR mutant non-small cell lung cancer.
EGFR positive. Okay.
Her initial staging brain MRI shows 8 asymptomatic metastases. All small, less than a centimeter. Her KPS is good, 90.
8 mets. Asymptomatic. EGFR positive.
Okay, the challenge.
Yeah.
Defend 2 different evidence-based management strategies. How do you tackle that?
Yeah, this is a great scenario because there truly are 2 valid evidence-supported strategies. They're quite different, though.
Okay, what's strategy number 1?
Strategy 1 is to defer radiation initially and lead with systemic therapy.
Start with drugs first.
Yes. Specifically, my recommendation would be to start treatment with osimertinib. That's a targeted therapy, a TKI, that works really well for EGFR mutations. Hold the radiation in reserve.
That seems counterintuitive for 8 brain mets, even small ones. Why osimertinib first? What's the thinking?
It comes down to how well osimertinib works in the brain. It has an exceptionally high intracranial response rate. We're talking 65 to 70%.
Yeah, that high. Inside the brain.
That high. So by starting systemic therapy first, you're treating not only those 8 known spots, but also potentially any microscopic disease elsewhere in the brain or body that we can't even see yet on scans.
Ah, treating the known and the unknown.
Exactly. Then you'd get a follow-up MRI pretty quickly, maybe in 2 to 3 months, to see how well it's working intracranially.
Okay, so that's strategy 1. Osimertinib first. Watch closely. What's the second valid strategy?
The second strategy is the opposite approach. Upfront stereotactic radiosurgery. Hit all 8 lesions right away.
SRS to all 8 spots from the get-go.
Yeah. This is also a very reasonable approach. The justification comes partly from the Yamamoto trial.
Yamamoto trial.
Yeah, it basically showed that using SRS for even up to 10 metastases can be feasible and effective as long as the total tumor volume isn't too large.
So number isn't the only factor, total volume matters too.
Right. And with 8 small mets, the total volume is likely low. So this approach gives you immediate, definitive local control to all the sites you know about, zapping them right at the start.
Is there any other evidence supporting upfront SRS here?
There is a retrospective study from Yale by Magnuson and colleagues.
The Yale study. Okay.
It specifically looked at EGFR mutant patients like this one, and it suggested that getting upfront local control with SRS, followed by starting the TKI like osimertinib, might actually lead to better overall survival compared to TKI alone first.
Oh, interesting. So maybe hitting the hard locally first helps the systemic therapy work better long term.
That's the hypothesis. So you see, you have 2 strong evidence-based paths with different philosophies. Osimertinib first for systemic control, or SRS first for definitive local control.
That's a true dilemma. And if you chose upfront SRS, the planning would be similar.
Pretty similar, yeah.
Yeah.
SRS to all 8 lesions. Doses would follow RTOG 9005 based on each lesion's size. And you'd have to be really careful about that cumulative dose to normal brain, that V12. Keep the total V12 from all 8 spots below that 10 cc limit.
Right. Gets more challenging with more targets.
Definitely. Requires meticulous planning.
Okay, fantastic discussion of the cases. Let's shift now and crystallize some key takeaways. Time for some clinical pearls.
All right, let's do it. Pearl number 1. For resected brain metastases, remember post-operative SRS?
SRS to the cavity.
Right. It offers equivalent overall survival, but significantly less cognitive decline compared to WBRT. That's the NC-CTG and 1070C trial takeaway. Prioritize cognition when survival is the same.
Excellent. Pearl number 2.
Pearl number 2. For patients with limited brain mets, say 1 to 3, SRS alone is the gold standard.
Just SRS.
Just SRS. Alliance N0574 gave us that level 1 evidence. Adding WBDRT hurts cognition, doesn't help survival. Less is more here for preserving brain function.
Got it. And pearl number 3.
Pearl number 3 relates to that last case. When you're dealing with EGFR mutant non-small cell lung cancer brain mets, remember how well-targeted therapies like osimertinib work intracranially?
Their high response rate in the brain.
Exactly. That high response rate makes deferring radiation and starting systemic therapy first a totally valid strategy. But upfront SRS for local control is also very valid, possibly even with a survival advantage based on retrospective data. It highlights that sequencing dilemma.
Perfect pearls. Ready for a quick board blitz. Test our recall.
Let's go. Hit me.
Question 1. 65-year-old woman, gross total resection of a solitary 4-centimeter left cerebellar met from breast cancer. What adjuvant radiation strategy is preferred to preserve cognition while maintaining local control? And what's the key trial?
Okay, preferred strategy is adjuvant hypofractionated SRS to the resection cavity. Key trial supporting that is NCTG N170C.
Nailed it. Question 2. 45-year-old patient, metastatic melanoma, 3 asymptomatic brain mets found on surveillance. What's the evidence-based recommendation for initial management?
That would be SRS alone to all 3 lesions. Evidence based on Alliance N0574 showing no survival benefit and worse cognition with added WBRT.
Excellent. Question 3. For that 4-centimeter surgical cavity we talked about, what type of SRS regimen is appropriate to reduce radiation necrosis risk compared to single fraction? Give an example dose.
Okay, for a large cavity, you need hypofractionated SRS, not single fraction. Example regimens would be like 30 gray in 5 fractions or 27 gray in 3 fractions.
Perfect. Last one, question 4. That EGFR mutant lung cancer patient with 8 asymptomatic brain mets, all under a centimeter.
Oh.
Name 2 valid evidence-based management strategies you could defend.
2 valid strategies are: 1, defer radiation, initiate osimertinib first, banking on its high intracranial response. 2, upfront SRS to all 8 lesions, aiming for immediate local control, supported by Yamamoto and potentially Magnuson Yale data.
Fantastic. You passed the blitz.
Ew.
So that last question, it really brings us right back to a major discussion point, maybe even a controversy right now in the field. How do we best sequence SRS and these amazing modern systemic therapies, especially for these molecularly driven cancers like EGFR mutant lung?
It's such a fascinating and evolving area. Like we discussed, starting with a highly effective drug like osimertinib first is compelling,
I know,
right?
because it works so well in the brain.
Exactly. Excellent CNS penetration, high response rates. It could potentially delay or even avoid the need for radiation for some patients. Plus, it treats that micrometastatic disease systemically.
Makes a strong case. But what's the argument for SRS first again?
Well, the flip side is that upfront SRS gives you immediate, definitive local control of every spot you can see. You know those are treated.
Peace of mind locally.
Right. And then there's that Yale data from Magnuson suggesting maybe a survival benefit if you do SRS first, then the TKI. It's still debated retrospective data, but it's out there.
So the optimal sequence isn't totally settled.
Not completely settled, and it's a moving target as even newer drugs and combinations emerge. It really requires individualized decision-making.
Okay, let's try to summarize what we covered today. It was a lot, but really practical.
Yeah, I think we really solidified the clinical reasoning for brain mets management by working through those three pretty challenging oral board-style cases.
We definitely detailed the whole process for a large symptomatic cerebellar met surgery, the importance of fractionated post-op SRS.
Yep. And we strongly justified using SRS alone for that younger patient with just a few intact mets, hitting hard on those key trials about preserving cognition, Alliance, and Neuro-574.
Crucial trial. And finally, we really debated the nuances of sequencing SRS and targeted therapy, specifically for that EGFR mutant lung cancer case with many small mets. Showed there are two good options.
Exactly. And the common thread through all of this, I think, is clear. Optimal management needs a deep grasp of the evidence. You've got to tailor the right treatment to the right patient.
Always balancing that disease control with preserving quality of life, especially cognitive function.
Couldn't agree more. That balance is key.
Well, this has been incredibly insightful. For everyone listening, you can complete practice oral boards and find more resources at radonsmartlearn.com. That's RADONCSMARTLEARN.com.
Great resource.
And be sure to subscribe to Radon Smart Review for our next session.
Thanks for tuning in, everyone. Hope this was helpful.